Welcome to OsteoBites. We hope you have your snacks ready to crunch on because we have such an exciting session today. I brought my apple slices, not because I'm particularly healthy, but mostly because I ran out of double stuffed Oreos. My name is Anne Graham, and I'm an osteosarcoma survivor. I started MIB Agents in 2012 with the mission to make it better for kids with osteosarcoma. Our mission continues today by providing direct patient and family support, by bringing together the physician and researcher community to work together to make it better for osteosarcoma families. And OsteoBites is a part of that coming together so that we can learn from each other on how we can work to make it better, which both parties really need to be involved in and both parties are really desperate to do. We're honored today and really truly excited to have the Osteosarcoma Institute chatting with us about their extraordinary commitment to osteosarcoma research and of course to osteosarcoma patients. I'll ask Dr. Lee Helman and Joyce Schaffer, who's their nurse navigator, to introduce themselves, followed by panelists Amanda and Florencia. Dr. Helman?
Okay, let me make sure. No, I'm unmuted. So, hello everybody. My name is Dr. Lee Helman. I am a pediatric oncologist and I have been studying osteosarcoma for 30 years. I hate to admit it. And I had an active research laboratory program for the last 32 years. I spent about 30 years at the National Cancer Institute, was chief of the pediatric oncology branch, and then scientific director for clinical research at the NCI. And the last 3 years, I was at Children's Hospital Los Angeles. And after 3 years, I decided to put most of my efforts into working with the Osteosarcoma Institute, trying to improve the outcome of patients with osteosarcoma. And I am now back in Bethesda.
My name is Joyce Schaffer. I am an advanced practice nurse, and I reside in Phoenix, Arizona. I work at Honor Health Research Institute, and I am I'm a very seasoned nurse. So that, you know, when you're over 20 years experience, we just go into seasoned instead of old. So seasoned nurse, have been working in the area of cancer oncology for about the last 20 years. Specifically working as a nurse navigator for the last 15 years. And my role is very unique in that I am a virtual nurse navigator. So I know nurse navigator is very familiar to a lot of individuals. First started out in the breast cancer arena. Where I work specifically, I work in research. And so I have the opportunity to talk and email with individuals all over the world, educating them about clinical trials in all areas of cancer, and navigating them to the right place at the right time for their treatment. Specifically to osteosarcoma, I have the opportunity to be their nurse navigator, again, connecting the dots for patients, for families, because of its rarity and difficulty to treat, have the opportunity to connect them with experts and provide support.
I'm Amanda, representing all of our OS families. I am an almost 33-year survivor, and since then, I've also had breast cancer and now ALS, which is why my speech is affected, but I'm here for you always, and it's so nice to meet people from the Osteosarcoma Institute, so thank you.
Hello, my name is Florencia. I am the administrator for the Osteosarcoma and Youve Sarcoma Facebook group. That is a global platform. It's a support group for patients, families, and carers of people with primary bone cancer.
So we're going to start. And before we start, I will just ask anyone who's on the call, if you have a question, if you go to the bottom of your screen and hit chat, you can type in the question you want to ask, and Anne is going to coordinate getting the questions to us and we will answer them. We're going to start with talking about our patient hotline, the nurse navigator, and that's what Joyce helped us start. So we'll spend the first part talking about our hotline and what it is, what we hope to do with it. And then the second part, I'm happy to talk about research or questions you have, what's currently going on, we know we still need, we have a long ways to go, but I'm happy to talk about ongoing research and where the field is going and where we hope to make progress, because I never think of it as my patients failing. I fail my patients, and we know we need to do better. So Joyce, why don't you start talking about the setup of our hotline, and then I'll try to finish up and go over a few issues, and we'll take questions. If anyone has them, please type it in the chat, and then we can move on to anything else. Anything's fair game. We're just trying to be helpful.
Thank you, Lee. So with the Hotline Services, it can be found on the Osteosarcoma website, which is osinst.org. And if you scroll down, you find hotline information. There's the phone number there and the email address, so I'm accessible either way. It's actually my colleague, Andrea House, and myself who both man that line. If you don't, when people connect with us, a lot of times people say, I don't know what questions to ask, or I don't know how this works. Don't worry about that. That's where we're the experts. So you just connect with us. We'll ask you the questions about yourself or your loved one who you're reaching out on behalf. What's important to know is that the information that is shared with us is all very confidential. We go by the guidelines. Nothing is published out there, or your name doesn't go out there to any type of other email addresses for it's very secure. When we talk with individuals, we then, once all the information is received, a lot of individuals are being treated at institutes that use an electronic medical record system that's similar to what we use, so that makes access of information very helpful. And we can acquire a plethora of information in that way. If not, then we just request information. It's absolutely no big deal. But once we get all the information, what we do then from Andrea and my standpoint is then we connect with Dr. Helman. We share the information with him, and then a conference call is then set up between ourselves, Dr. Helman, and the individuals inquiring, just reviewing the history and seeing how we can be of best assistance. Is there a physician close to you or someone that we can set up a consultation? In these COVID times, it kind of puts a whole different slant on everything, because usually it's like, oh, let's just get you down the street or across a couple of states for a consultation. But with travel and everything, there's a lot of virtual consultations taking place. So again, that we would take that into consideration as well. Anything else, Dr. Helman?
Yeah, let me just make two comments to start, and thank you, Joyce. Well, I know, so again, I've been taking care of patients with osteosarcoma since 1983. So I've been around the block a little, and I've seen, you know, an incredible increase in our ability to treat, and then sort of a lull over the last 25, 30 years. But the reason we ask, because I know some people don't like to give the intake information, and the reason we just ask for information is so that when Joyce calls me, I have some background so I know what it doesn't help if I get if I call cold and then I have to ask you questions that you've already answered 100 times. So who is your doctor? When were you treated? What did you get treated with? And all these things. I have that information. So then I understand what you've already had, what your questions are, and we can start talking about what you're interested in rather than spending the first 20 minutes answering questions you're sick of answering already. The second point I really want to emphasize is that, again, been doing this for many, many years, is I am very careful when we know it's standard treatment. Most patients that are newly diagnosed get very similar treatment. I'm sure any of you that have been treated, you get usually now preoperative chemotherapy and then surgery and then more chemotherapy. and hopefully you finish, and then we watch, and we hope you don't recur. Once you recur, there probably is the one go-to drug, because we don't treat patients, at least in the United States, initially with ifosfamide. Everyone gets adriamycin, cisplatin, and a high-dose methotrexate. I would say most patients, if they recur, they'll usually get at least ifosfamide, maybe ifosfamide and another drug. Once you've had that, there's no right answer after that. You know, you'll talk to 8 doctors and you might get 8 different answers. And so what I always make sure I let people understand is, once we get past those first 4 drugs, there's no one size fits all. We try to understand what's important to you, what you're interested in, and then I just try to be as honest as I possibly can, realizing I don't have all the answers, none of us do. And so what I try to do is present you the information, the data. You've all probably been listening to the issues we're trying to deal with the coronavirus. And being a physician and a scientist, I believe that the more information we have, the more informed our decisions can be. That doesn't mean there's only one right decision, because ultimately that decision is up to you. And I've always treated my patients as a partner. So when we make a decision to treat, I'm serving you as the patient. I'm not the boss. We try to give you the information so that you can make the best informed decision you can make for yourself. So that's what we try to do. Now, the Osteosarcoma Institute was formed about, what, 1.5 years, 2 years ago? And that's one of the ways I got to know Ann, and it's been a pleasure to know Ann and all of you. I had a fantastic time at the meeting in Scottsdale. When was it? I can't even remember. September? No.
End of February.
February, recent.
Right under the COVID line.
Right before.
Yeah.
But we, as the Osteosarcoma Institute, wanted to make this this available as a free service to try to help all the patients. We're not pushing any institution. We're not trying to get patients anything but help. That's what and that's why I love the MIB group, because you all are there to help each other, and we're just trying to provide additional help. So I will stop there and maybe throw it open for questions at this point, if there are any.
Yes, question. So the process, if I call the number, which, by the way, I keep this next to my phone, literally, like, I love this little magnet. It's so good. If I call this number and I have a question, I will, first of all, what are the hours? When can I call?
Yeah, the hours, so we're in Arizona. So right now, I think we're Mountain Time. We never change time, so I forget. But anyway, we're in Arizona. So the hours are from 8 to 4:30. But of course, if you call outside of that, of course, there's a message you can leave. And we return calls within 24 hours.
Okay. So those are the hours. And then we will get either you, Joyce, or your partner, sorry, her name again?
Andrea.
And you do an intake with the caller.
Correct.
Do you answer any questions directly, or do you, after you do the intake, you contact Dr. Helman?
Good question. It depends on the questions. So Dr. Helman is the osteosarcoma expert. I'm the expert in nurse navigation support education. So majority of the questions will be directed by Dr. Helman. After the intake, what we do specifically ask the caller, or by email, it's like, what specific questions do you have for us? Because that really helps. As Dr. Helman already mentioned, you know, we get all that information together, and then we can kind of narrow down, if you will, what are your specific questions you have? And that helps him as well.
Okay. So if I call and I say, my child has osteosarcoma, they have a fever, it's 102, which is in the 103, or do I go to the emergency room? That's something you would likely be able to answer.
That is correct, yes.
Okay. And then if it's something like, just found out I have recurrent disease, what do I do? Where do I go? What's the next thing for treatment? That's something you would turn over to Dr. Helman?
Correct. After I would get all of your information. When were you first diagnosed? What treatment have you received? And real basic, what's your date of birth? You know, what's your name? You know, that basic information. What's your treatment history? What's your recent imaging? What surgery? So correct, get all of their medical, both history, treatment, and disease history.
Do you, in the process of gathering this data, between the time of gathering the data and turning it over to Dr. Helman, do you ever contact the treating institution or the treating doctor?
I do not, no.
Does that ever happen with, or, I mean, I guess you would have to get permission to do that. How does that work?
We would have to, correct. We would have to get permission for that. We do not, I mean, again, very strictly go by the HIPAA guidelines. So your information is for you to share. You have reached out to me or to us. So we will acquire that information, and we do not contact your physicians without, well, first of all, that's out of my scope of practice. If that's something that Dr. Helman would want to do after he has the dialogue and there's, he finds that, then that's up to him and the patient. And again, but that's out of my scope. I would not connect with them. Dr. Helman, do you want to comment on that?
Maybe just comment a couple of points I would make. First of all, again, because I've taken care of patients, my hands on patients, etc., I never tried a Monday morning quarterback. Mm-hmm. So I understand that, talking on the phone is not sitting in the office, seeing you, examining you. And so I try to be very careful. If there's, first of all, I hope that you've been treated with a physician you have a lot of confidence in, and you have already had these discussions, or at least started these discussions with your treating doctor. If in fact your treating doctor is like, well, you should talk to other people, and when I saw patients, I would always say, if you want to talk to someone else, I'll give you 3 other experts. But I would be happy if the caller said, would you be willing to have my doctor call you? Of course, we would be happy to do that with your permission, with your doctor's willingness to do that. And one of the things that I learned is a lot of times, if you are unfortunate enough to be diagnosed with a recurrence, you're in shock. And so your doctor may be telling you all these things, and you may hear 1/2 of what they've said. And I understand that, and hopefully your treating doctor understands that. And sometimes you just need to hear a few things a few times, because you don't get it all the first time, just because, we've all been shocked by things, and we know we're not functioning at the right, we miss things. And so all of these things we're very cognizant of. And so we try to work with you and understand what you need to hear, how you need to hear it, and from who.
Okay, this is such a gift to the osteosarcoma community, because there is no charge for this.
No.
You're getting a second opinion on your treatment without flying anywhere, without getting in your car, without contacting insurance. You're getting a true expert to weigh in on your treatment. This is extraordinary. This is truly extraordinary. And we just got a question: is there a charge for calling to ask the questions or any of the follow-up? And I don't normally answer for the for you, but I know the answer. It's no, and that's why this is such an extraordinary.
And I should be clear. We started this actually in April, but it really rolled out in June. And frankly, we've been surprised. There've been not that many calls, maybe 5 calls. And so we're paying some money for this, but it's what we want to do. But obviously, we don't want to keep doing it if it's not necessary. And I know there are lots of places, and when I was working at CHLA or at the National Cancer Institute, I took 1 or 2 calls a week and a lot of times they were patients who were being treated by friends of mine, by colleagues. And so You know, if it's not helpful, we can put our money somewhere else, like to find new treatments. So, you know, we're happy to make this available, but we want to know whether or not it's necessary. And we don't, you know, we're not invested in knowing that it's necessary. If people have other ways to deal with this, we're happy as long as patients are getting their needs met. That's what we want to do. We
Correct.
want to serve patients just like you do, Ann.
So do we call, is it fair to say you can call this number for a second opinion?
Yeah, let me, you know, I'm a little nervous about second opinions, because a second opinion, I believe, requires a person, you know, an office visit. What I would say is this is more navigation. It's going through your history, knowing you have a physician who's an expert in osteosarcoma, I hope, that can reflect, go over the questions you have and give you options, and try to help you then. If you want to go get a second opinion, we can give you names. If you want us to talk to your doctor, we'll be happy to do that. I think it's not quite a second opinion. I really see as someone's coming to see me in the office, and I do a full exam and I go over the history and I sit down and I talk face to face. This is a little bit different than a true second opinion. In fact, I would say if you want a second opinion, ask your doctor to refer you to another physician.
Are all of the calls that you do all via audio call, any video call, or strictly audio?
Well, it's all been audio, all phone calls to date. But you know, listen, the whole world's changing. I've done more video calls, you know, since this happened, and we've all been, you know, isolated at home. This is my second. I have one more video call after this, so we'll see how the technology, you know, evolves, but we'll see.
And I just want to make a comment regarding the, this is not to replace your oncologist who's taking care of you there at home in your backyard. So it's that physician that can put the stethoscope on you, do a full assessment. That's the expert at the time, because they can care for you. So I just want to emphasize that. And Dr. Helman said very specifically, this is not a second opinion, because it's not good practice to provide medical advice over the phone. Well, historically over the phone or by video, but again, we will do the best we can because we want you to have the best care. So who are the experts? Who are support people? Whatever around you. Have you been connected with social workers or whatever entities are out there? That's what I can help provide as well.
Let me just, go ahead. Go ahead. I was just going to say, you know, again, over all these years, sometimes a patient just wants to hear, or a parent wants to hear, you've uncovered every stone, you've looked at every option, there's nothing else I have. You know, you just want reassurance that you've done everything right. Because look, I had a son who was diagnosed with a brain tumor. Okay, he's doing okay, but you know, I know what it feels like too. You don't want to leave any stone unturned. No. And so sometimes it just helps you to hear you've done exactly the right thing.
Yeah. Okay, new question. What recommendations do you make for patients who call with questions about surgical options for the lower extremity?
Yeah, I think that was one that was on the list. So that's a really good question. And one of the things that went along with us figuring out that chemotherapy helped us make patients survive, many more patients survive with this disease, with the evolution of chemotherapy also became the evolution of what we call limb salvage surgery. So surgery has advanced a lot. When I first started, you know, most patients started out, they got amputations, and now probably less than 10% of patients with lower extremity tumors have amputations. The problem is there are several things that can affect that. If you're young and you're going to grow another 4 or 5 inches, it's a problem. And sometimes although, you know, it's kind of devastating to have an amputation. Some patients clearly do better with an amputation than with limb salvage. So there's not one size fits all. This has to be carefully discussed. And my recommendation there is you have an orthopedic oncologist who has a lot of experience with osteosarcoma specifically, and you discuss the options. Most of the time, like I said, about 90% of the time, we go with a limb salvage, but not everybody has a limb salvage that works out. And sometimes it gets infected. Sometimes you have breakage of the prosthesis. And in the end, patients can have a couple surgeries and just get, you know, end up with an amputation and do fine. So I think there's no one size fits all. And this is a really important discussion. When we see a newly diagnosed patient with osteosarcoma, I'm sure this is what happens in most institutions, you have a multidisciplinary tumor board that always includes an orthopedic surgeon. And we go through the options. And, you know, you don't have to make a decision, a snap decision. Usually you have time, because usually we give about 10 weeks of chemotherapy before the surgery. So there's so many factors that go into it. And the most important thing is what you or your child is willing, you know, if you just said, I'd rather just have an amputation or if the surgeon says, you know, I think at this point, at this age, you do better with just an amputation and a prosthesis. I've seen people playing soccer after an amputation. So it just depends.
Okay. We have a friend of yours checking in, Dr. Helman. Says, hi, Lee, it's Kurt. You know which Kurt this is?
Yes, of course. Hi, Kurt.
He says, you look great. It seems like in terms of locally recurrent disease, there is not tremendous guidance for surgical or medical management. Anything new under the sun for patients with recurrence?
Well, Kurt's an orthopedic surgeon. If it's the Kurt, I think it is.
It is.
He's a fabulous surgeon. So Kurt, I would say, you know, you would know more about the surgical options.
I turned his microphone on.
Okay.
Hello, Dr. Weiss.
Hello, ma'am. Hello, Lee.
Hi, Kurt. Beautiful picture I see of you.
Hey, thanks.
You're welcome. You know, I think as we talked about in terms of, you know, local recurrence, the one thing we know at this point is the best predictor of a patient with a local recurrence having long-term survival is the ability to totally resect the local recurrence. And so we usually have a very good discussion with our orthopedic surgeons. In terms of once you do that, what chemotherapy, you know, we don't know. There are options. I would probably my own personal opinion is I would opt to do the surgery and then follow it with some kind of systemic therapy, but I would have to have a discussion, because it wouldn't be wrong to say, well, why don't we just wait and see? We don't have an answer to that yet. That's because I think we need better salvage systemic therapy.
The reason why, can you hear me okay, sir?
Pardon me?
Can you hear me okay?
Yeah, I can.
The reason why I'm asking the question is because I was in this situation last year and I was shocked that there wasn't a very clear protocol. Well, this is what you do, then this is what you do, then that's what you do. And I looked through the literature and, you know, holy cow, there isn't a clear guideline on how to crack this nut. And I guess that kind of shocked me. I sort of expect metastatic disease to work that way, but I did not expect local recurrence to work that way.
Yeah, well, it's unfortunately the state of affairs, Kurt, and that's why, again, I'm currently writing a review on osteosarcoma, and you'll be interested to know I just reviewed the 15-year history of MTPPE, so all of the data. And anyway, you know, we just don't have solid answers on that. I think we're getting there. I think we're starting to learn a little bit more about the biology. But I can tell you, Kurt, I have a patient who had a soft tissue recurrence about 10 years. That means instead of in the bone, it recurred in the the tissue around the bone. And the patient's tumor completely went away with ifosfamide. And so there was nothing, because we were going to treat with ifosfamide, look at it, and then do surgery. And it totally went away with ifosfamide. It never came back. So even though all the literature says you have to do a resection of all the disease, and I fully subscribe to that, this patient had such an incredible response, there was nothing to go resect. So we don't have the answers yet. And part of it is because, we're still curing 50% of newly diagnosed non-metastatic patients. So fortunately, local recurrences are, rare enough that to do a big study that would require, 200, 300, 400, 500 patients with local recurrence randomized to resection alone versus resection plus chemotherapy could take a long time. So we're struggling with the right thing to do. And that's why I started the discussion with saying there is no one answer. Usually after you get by upfront therapy and maybe ifosfamide, beyond that, everyone's got an opinion, and that's because there's no clear answer.
Mm-hmm. Okay, quick question. I think it'll be a quick question, quick answer. Can you call this number to get some help or advice on coping? Even if you have a great relationship with your doctor, it's nice to have someone else to talk to who understands osteosarcoma.
Absolutely, yes.
Great. Amanda, do you have any questions for the panel?
I think everything has been asked. I think what you're doing is amazing. So it's more of a statement than a question. I do have a question though. How come no one ever goes back to the older chemos? I have received answers and I'm very grateful. But I was on 4 chemos that they do not give anymore. And it kills me because I'm alive to live 4 other kids I was diagnosed with. So they never ever will go back to those older chemos?
Well, I'm not sure which older chemos. When we first did the study back in the 1980s that proved that chemotherapy, we took patients with non-metastatic disease with localized extremity osteosarcomas, and we randomized them to just have their resection or to have their resection and get chemo. And we stopped the study because the patients that got chemo did much better. At that time, we were using Adria, platinum, methotrexate, but also bleomycin, Cytoxan, and Dactino, BCD. That's probably what
I've been Christine with I never had cisplatin.
Yeah. Well, because over time, we basically threw everything but the kitchen sink at them. And over time, we were able to sort of say, well, what are the critical ones? And with careful studies over the next 15 years, it became clear that the bleomycin and the dactinomycin and the vincristine really weren't necessary. And if anything, probably made us give less of the most effective drugs. So as we carefully brought some of those down, we were able to maintain as good a cure rate with less toxicity, basically, is what happened.
I think it is very interesting to talk about the treatment variation, because I think, a long time ago, there were more chemotherapy drugs. Apparently, the treatment is slightly different, and that's interesting. How it's because now we have adriamycin, methotrexate, and cisplatin, which is quite a very aggressive combo in terms of side effects.
Mm-hmm. Florence is in Scotland, by the way.
Mm-hmm. Yeah, so it's interesting. There are studies going on in France, and there were studies, first of all, in the UK for a long time. I guess it's still the UK for now. For a long time, they weren't giving methotrexate, right? They were doing mainly adriaplatinum. And they did some comparative studies. And there are patients that did just as well without the high-dose methotrexate. But over time, even their studies showed that in general, the patients who had a poor response did much worse with just adriaplatinum than those who got the 3 drugs. So even they moved to the 3 drugs. Now there are some studies going on in Europe where instead of giving adriamycin, they're relying more on ifosfamide. And of course, and they're getting similar results because they think that giving adriamycin has cardiac toxicity. And look, there's not a single drug we give that there's not a price.
That is right, doctor. That drug is very dangerous. I did have a little bit of problems with my heart after the treatment. Then I needed to get some tests because actually it was very worrying. It went away. Thankfully, I was really lacking this aspect. But I know that a lot of people need medication for the rest of their lives.
So that's why
it's very aggressive.
Yes, that's why they're starting to look at these combinations. And there was just a publication showing that using a different regimen without adriamycin and ifosfamide, those patients seem to do quite just as well as the 3-drug combination that's pretty standard across Germany and the United States and the UK. However, ifosfamide's not a freebie either. So ifosfamide has a lot of toxicity too. So the reality is, and one of the reasons we don't give 4 drugs, that was tried in Italy. And by adding ifosfamide to adriaplatinum methotrexate, the toxicity was higher. So, and so in the end, it is a toxic, whatever we give, the toxicity is high, the long-term side effects are high. We understand that, which is why we're working so hard to try to figure out if there are other ways, such as immunotherapy or less toxic ways, or because, the other thing we know now is that we treat all newly diagnosed, non-metastatic, high grade osteosarcoma the same. So, and we know there are differences. It's not all the same. So as we begin to better understand that some of these have a mutation in RB and some of them have a mutation in CDK4 and some of them have, we probably will ultimately start treating different groups slightly differently, but that has to be done safely. So the worst thing we'd want to do is treat them with new drugs and have them do worse. So have them have less than a 70% cure. So it's going to take time, but I believe over time we will get there. And some patients we will be able to give less toxic and more targeted therapy, but we're not there yet.
That would be wonderful.
Do you know if there are any new drugs or trials on the horizon? Because these are all older drugs, and everyone, I think, wants to know if there was new, even in a year or two, that might be coming into.
Yes, well, there are two parts to that question. The first thing is, there are many studies now looking at in recurrent patients. There are several studies that showed some activity of regorafenib. There are some studies showing activity of cabozantinib. So these are sort of these anti-angiogenic drugs. Now people want to look at the combination of that plus an immune checkpoint inhibitor, because immune checkpoint inhibitors by themselves were pretty negative in osteo. We saw, very few patients respond, maybe 10%. So that, if it looks promising, and we're trying to do studies with smaller numbers of patients looking for an early signal that then we could expand, because remember, this is a rare tumor. So to do a big study where we do a randomized this treatment versus this treatment takes hundreds and hundreds of patients and years. So we better have something that looks good first in a small group of patients. But there's a lot of interest now in trying to figure out how to make immune therapy work. And, you know, there were hints of that. And the MTP seemed to be having a hint that immune therapy can have some activity, but we still don't know to who and how. And so we still have some work to do, but there are studies going on now. There's 2 studies, one in Europe and one in the US, that's going to look at regorafenib plus an immune therapy. And I think another study looking at a similar drug, cabozantinib, plus an immune therapy. So we're trying to get more information with less numbers of patients. And again, because we're, you know, for patients that don't have metastatic disease and have localized extremity osteosarcoma, we're curing, you know, 65 to 70% of those. It used to be less than 10%. So you don't want to lose what we have by trying something that's going to be worse. So it's, and that wouldn't be a problem in breast cancer where there are a couple 100,000 cases a year. We're talking about 500 cases a year in the US. So we have to be careful and make sure we do it in a systematic way.
So I can, to partially humbly also add 2 cents to that. There's never been a better time in osteosarcoma than in the past couple of years, with organizations like the Osteosarcoma Institute, with really the patient and physician community coming together and working together, sharing as we have, but on a whole new level, legacy autopsy, biodata, genetic profiling, all of these things. And together with all of us working together as one community is really changing osteosarcoma. And we are due, like everybody knows that we are due for better. So it's really because of organizations like the Osteosarcoma Institute, which I really hope that this helps the greater osteosarcoma community, and really through Florencia and Amanda, who are on the front lines of what I call the dark night of the soul, when you get a new recurrent diagnosis, or when you're really struggling with some aspect of this disease. Where people go to are Amanda and Florencia, and they ask the questions. And now I think we have this tool that, between the 3 of us, the 2 big Facebook groups in MIB, we can go, listen, none of us give out medical advice, but we do provide resources, and this is an extraordinary resource for us. We got one comment while we've been talking that this person knew that there was a nurse navigator on the other side of the line, but they didn't know that ultimately this was going to be somewhat immediately given to Dr. Helman. There's this kind of support for that caller. So I think now that we know this, and we've had a chat, and we know who's on the other end of the phone, I think we can really use this resource and recommend this resource to people who call and say, what do I do? And they're really asking people who are not qualified or comfortable giving out medical advice. So really, really important. Really happy you were here today to talk about this. And we're out of time.
Okay.
So I told you this is going to be an exciting session. This was so good. So next week, by the way, we have Dr. Matteo Trucco of Cleveland Clinic, and Dr. David Loeb of Children's Hospital Montefiore and Albert Einstein College of Medicine. They'll be talking about a clinical trial on upfront surgery for osteosarcoma. It's a clinical trial concept, which is pretty exciting. So we'll be talking about that, same place. Note that we have OsteoBites sessions every week with the leaders in osteosarcoma, talking about their work and asking questions. you can, answering your questions, you can go to mibagents.org for post OsteoBites videos of sessions past. This video will be up on Sunday, and we share it on MIB's social media pages, and Florencia and Amanda also share this video. That's it. Thank you for joining us today, Dr. Helman and Nurse Joyce. Most of all, thank you for the work that you undertake every day in support of and for osteosarcoma patients that you serve.
And thank you, and please stay safe, everybody.